Okay, whoops. Okay, excellent. This is an area near and dear to my heart. When I initially started, I was in general surgery. I did a year of general surgery, and then I was going to be an orthopedic surgeon. And I discovered emergency medicine and thus changed the trajectory of my whole career. So that's pretty exciting, a little known fact or a known fact. But anyway, I have nothing to disclose relative to this. And I'll start out with talking about fractures in childhood. And some of the principles that we have to consider is the age and the mechanism, because that's going to make a difference because there's certain fractures based on age. You always have to consider the possibility of intentional injury. Unfortunately, this is something that is our responsibility as mandated reporters. So we're going to have to think about these things. What type of injuries are possible child abuse? We'll cover that briefly. And then consider soft tissue injury. Is it open or closed? That's going to be important in terms of management strategies. Consider fractures involving joints because that also made a difference in terms of the need for closed reduction or open reduction. And you always want to make sure that the exam includes neurovascular function. I think this is really critical because some fractures, especially a very common fracture like supracondylar fractures, can involve a neurovascular compromise. And then I think I want to say is a real important take home is you always want at least two views, okay? So a singular view can be very, very misleading. And we've had a number of incidents where you took the baby gram or whatever, or you took the one shot and they said, oh, this looks good enough, but you always want to get two views because you can be fooled. And then you will also want to consider x-rays above and below. And if you look to the right, this is from Up to Date, but it's kind of nice because it shows the wrist and all the types of shots you should get in terms of x-rays, AP lateral oblique, and say the shoulder, AP scapular, and Y. We always do 3 views of the shoulder. And you can see that the types of x-rays that one would order. The other thing I think to consider is what fractures, as I mentioned, are more common to be considered for child abuse. And certainly multiple fractures of different ages that are healing, I think, or anytime there's multiple fractures involved, I think that's important, but certainly those at different stages of healing. Skull fractures, I think, can be considered, especially complex skull fractures. A story of a fall striking the head with a single linear skull fracture is unlikely to be child abuse, as an example. Some other things to consider are rib fractures. As you know, the ribs aren't fully calcified. It takes some great force to break the ribs. The most common, multiple rib fractures, you really need, without a really high kinetic mechanism, you really have to think about child abuse. The other thing to think about is humerus fractures other than supracondylar fractures. Those are typically a direct blow to the humerus. And it has been reported that 100% of those under the age of 3, it's not really 100%. I have seen some accidental. As an example, little Johnny's with the older brother, and little Johnny runs in front of older brother who swings a baseball bat, at the baseball field and strikes little Johnny, and it's witnessed by 5 people. I mean, this is not something that I would report, but I do believe that you have to think strongly about humerus fractures. And the one thing I will say that I think is also really critical is that we have found that it is really important to look at all of your x-rays, and the classic one are chest x-rays. And it was interesting, a child came in with a fever and I looked at the chest x-ray and I realized it was a 2-year-old with a healing humerus fracture. And if you focus on just what you're interested in, you're going to miss these types of things. So just a point of fact, when I think of humerus fractures, I think of that 2-year-old with fever, and I go, oh, she doesn't have pneumonia, but you always want to go from the outside in, and she ended up having child abuse. So fractures of long bones, it may be those who are not walking. I would be very, very concerned about fractures of long bones. And then again, fracture without any trauma history that presents with evidence of healing. It's a consideration. None of these are basically 100%, but these are considerations. And then I had mentioned this in the case review when we went over the 3 cases, that it has to be a fall from a significant height in order to break a femur. And it has to be at least greater than 2 feet. So anything less than 2 feet, it's highly unlikely to break a femur. And generally, kids break femurs as they get older and they get enough kinetic energy to be able to twist or fall or run enough with enough speed to have that happen. Can it happen that the child rolls off the changing table? I would say yes. But again, you want to put everything into context. And these are some examples. As you can see on your left, that's a healing femur fracture. And this is a kid who family brought him in and for leg swelling, and had a healing humerus fracture, which was child abuse. Again, skull fractures, they typically are going to be complex. They may have multiple components to them. Rib fractures, especially posterior rib fractures. This is a kid, this is from the AAP slide set, not only has a humerus fracture, I'm afraid you can't see it, but also has a healing forearm fracture. And the classic ones that we see are the metaphyseal chip fracture, as well as something called the bucket handle fracture. Generally, these are torsive or twisting mechanisms. Now, moving on to something that we see every day as most common fracture are green stick fractures. There's about 50% of children. And they're incomplete fractures, typically the metaphyseal, diaphyseal junction, as you can see from the diagram there. There's also bowing fractures, which are microfractures all along that metaphyseal junction. And the classic ones that I've seen with that are kids that come in and you look at their arm, let's just say, and you go, that kid has, that kid has a fracture hands down. And you get the x-ray and you can't find the fracture. This is a kid that's like, get the comparison view, you'll see it, or just you can make the assumption that that's a bowing fracture. And angulation and rotation can be common with these, so sometimes they cause or necessitate closed reduction. So the classic green stick, pain control, closed reduction to either complete the fracture. If it involves both bones, you may not need to do that, and then immobilize. And this is an example of, you can see the comparison view and the bowing fracture. These can be pretty subtle. And again, what I've seen with the bowing fracture, I don't know if my colleagues will comment, but again, they look like they have a fracture and you don't see it on it, and then you get the comparison view. And these actually require operative reduction. The ones that we see all the time that you can manage pretty handily are the torus fracture. These, I love these. You can pick them up. They can be pretty subtle, as you can see here. They often just have, it looks like they have just a little bump in the cortical bone. And you can see a couple examples here. And these are really, really common. We see on an outstretched hand. This is a common one. The distal form is really, really common because kids fall down and go boom a lot, and they try to, not all kids, some kids don't put their hands down, right? Depends on their age, but if they put their hand down, then they're going to break something, and it often is the distal forearm. Studies have shown that you can use removable splints for these, which is really nice for parents, although it can drive you crazy because the child is constantly trying to remove the splint. But I will say they're great because you can bathe them and then put it back on, and I think these are really useful. And there is probably in the distal forearm, they're as good as casting. Otherwise, they'll have casting. And the classic Salter fracture, I can tell you you can see the normal. The type 1, it's a fracture through the physis. And what you see on x-ray is a widening of the physis, or you don't see any abnormality. And this can be really tough. If you don't see any abnormality, but they have significant pain, one thing you can do is just splint them and then bring them back for re-x-ray or refer them for re-x-ray. But we typically would like to immobilize the type 1 fractures. And I think they're more common than you see here. The most common is type 2 fractures, which is fracture through the physis and into the metaphysis. These are by far the most common of the Salter fractures and the ones we see all the time. Type 3 are through the physis and into the epiphysis, as demonstrated with the diagram there. And type 4 are also about 10%. That's through the physis and into the metaphysis as well as the epiphysis, so through. So it's split, meaning going through the physis, above, meaning into the metaphysis, although it may be below, but let's just say it's into the metaphysis. And then lower is into the epiphysis, through is through both. And then finally 5, thank goodness these are the most uncommon. And this is a crush. Usually it's a significant axial load that results in crush of the area of the epiphysis. And the reason why these are the most challenging is because you get different areas of the physis will have increased blood flow, and that results in abnormal growth, either no growth in one area and growth in another, which can lead to deformities. And you can also have discrepancies, especially in the lower extremity in terms of leg length. So Salter 1 split, this is an x-ray. I don't know if you can see it that well, but if you look on the right, let me see, it's hard for me to point on this because but on the right, it is in the posterior part. You can see widening of this physis as compared to this part. This was a kid who came in with a shoulder injury, and I got the comparison view because I highly suspected that he had a fracture, and he did. He had a Salter-Harris type 1 fracture. And in the other diagram, which I got from Up to Date, you can see there's a little bit of widening of the physis, but I think it's super subtle. And so again, if there's significant pain, you can splint, refer, and then re-examine. So here's the one with the Salter-Harris one. Again, the most common, as you can see in the x-ray, there's a both bone fracture of the forearm, and you can see how it goes from the physis into the metaphysis. And all I can say is that with something like this that is displaced, if you have any question, any displacement, I consider certainly rotational effects. I would call ortho for potential in this case. There's angulation as well as displacement that you might want to consider calling ortho here. I would call ortho for closed reduction. One comment about closed reduction in children, if you're going to do it, I like to do it pretty quickly. They heal really fast. So within the first week, it's sticky and it's very difficult to close these and reduce these. So I would do it certainly under a week. They can be referred for this, but we got so good at sedation now, everybody leans on us, right? And we end up sedating these kids in the ED. Here's a Salter-Harris type 3 in the distal tibia. You can see it goes in to the epiphysis. And in general, unless there's significant displacement, as in the diagram, if there's non-displaced, in this case, the mortise is disrupted, so you would want some type of closed reduction. Salter-Harris 4 is through, and this one's non-displaced. The mortise actually looks really good, so I would still talk to ortho about these, but This is one, the only problem with this is that there may be some movement. So this may be something that certainly they're going to want to cast in the question. I don't think they can do much in terms of closed reduction here. So probably casting and non-weight bear. And finally, Salter-Harris type 5, this is in the wrist. And what you see is bone on bone. And if you notice, these can be really subtle, but what you see here is, see this white line? This is crush. This is bone impacting bone. And so this is a classic Salter-Harris type 5. And these are quite unusual, definitely a very poor prognosis because of various growth arrest that occurs at the level, because the osteoclasts get disrupted and there's abnormal, basically vascular response. So you do see some hypervascularity and low vascularity sites. Okay, can you name those Salter-Harris? I'll let you think about that. And this is Salter-Harris type 4. And again, it doesn't look really disrupted. Anything that involves the mortise, I like ortho to have eyes on it. All right, next is a classic scenario, a 16-month-old with a limp. The mother brings her 16-month-old girl to the ED because the child refuses to bear weight. Usually these kids bear some weight, but they're limping. So the classic is limping. I do have a little bit more concern when they're fully non-weight bearer. You have to think about something else. One of the things you have to do is, especially with limp, and I'm not going to get into a big differential on limp because that would take an hour, but the bottom line is that has no medical problems, no fever, no systemic signs. That's all really good in terms of thinking about other things like transient synovitis, septic arthritis, etc. This is a classic story of a toddler's fracture. What I find tough about some of these kids who come in is you're trying to figure out where anatomically is the problem, right? Is it in the foot? Is it in the ankle? And you got to think of what's common. Kids don't break their feet often or their forefoot, right? Or their tarsal bones. They just don't do it. So you take the mechanism or lack of mechanism, the fact that this is a toddler and they often are running in one direction and they change their mind, but their foot is planted and cause a torsive force, which results in a toddler's fracture. And these are oblique, sometimes spiral fractures of the tibia. And the problem with this is that because it's caused by their own kinetic forces, it's not enough force to cause displacement. And so they get a torsive force which causes the fracture, but not enough to cause displacement. So this can be problematic. And here you see a view of this right now. So what do you do for toddlers fractures? Pain control, below the knee, walking cast for 3 weeks. What if you don't know? You could do a comparison view. I typically don't like CT them or anything. I mean, a CT would pick it up, but I mean, you could potentially try to ultrasound them and see if you see the fracture. I don't think I'm that good at ultrasound to do that, but I would splint and consider just repeat films, usually in about 10 days. We used to do bone scans, but those are, I'd say, passé. MRI, but then you got to sedate them. So I don't know. I just typically just get good follow-up for these kids. And my last case, just to keep us going and try to get us on time here. This is a 7-year-old boy brought in by paramedics after falling off his bike. Patient holds his right arm in slight flexion with obvious swelling at the elbow, and the distal nerve vascular is intact. Otherwise, the trauma is negative. And this child, this is a classic supracondylar fracture. You look for this notching here, and there's some other signs radiographically, which I'll show you, but here's the notch, and you really look for that. You also look for this figure of 8. Some people call this an hourglass. And on a true lateral, it should just be perfect. And there's some disruption here. So not only is there's disruption in the hourglass, the anterior humeral line, I'll show you that in a bit, is off and there's a bit of notching. So this is a supracondylar fracture. And the problem is if it's displaced like it is here, then you can get vascular injury. And if it's displaced, up to 7% will have neurovascular injuries. So the markedly displaced supracondylars, these are the ones we always admit. And I'll talk about the classification. We call it Gartland classification, class 3A or 3B. Anytime they're markedly displaced, we will admit those patients. Not only do they need operative reduction, but they need frequent neuro checks. And this is going back. This just shows you the fat pads. This is your olecranon fat pad. And generally this is invisible on a true lateral. And what happens with the fracture is that the blood pushes the fat pad outward. Here's the anterior sail sign. We do see these, and it's demonstrated here. But the anterior sail sign can be normal, but it also can be expanded in fracture. But a posterior fat pad that is visible on a true lateral, okay, is always abnormal, and it can be that you just can't find the fracture. If you can't find the fracture, I would splint and refer. Okay. Let's look at the x-ray here. This is called the anterior humeral line. If you draw a line along the anterior humerus, it should bisect the capitellum, okay? And you can see it here. This is the supracondylar fracture I showed you. If you draw down, it does not bisect the capitellum. That's because there's mild angulation going posteriorly. So this is a hinge. This is a type 2 Gartland supracondylar fracture. These need closed reduction, but they can be sedate, closed reduction, and send them home. Here's the teardrop. Again, you can see it nicely here. This does not look like a nice little teardrop. You see some notching both in the front, and you can see a fracture line in the back, and it also has fat pad signs. So this has essentially all the signs. Here's the classifications. We used to admit all supracondylar fractures, but that was many years ago. We don't do it anymore. And the reason is because the type 1 supracondylar fractures that are non-displaced without significant hinging or displacement, as you can see with type 2, those are splint and refer. You can send them home. The type 2, as you can see here, anytime there's hinging and posterior displacement, that's closed reduction and send them home. And type 3, A or B, these are patients that need to be admitted. So anybody guess the type of Gartland fracture this is? You see there is some notching here, and the question is there a hinge or not? I would suggest that there is a slight hinge in this. This is somebody I would call ortho on. So this is a type 2, and this is certainly concerning whenever you get any type of type 3 Gartland fracture. All right, here's something is important for you to know about, and this is something emergency physicians miss, not infrequently, and this is a very important radiographic sign, which I think you're going to use this, I hope, every day in your practice when you do elbow films. And this is the radial head should always, it's hard to say always in medicine, but should always line up with the capitellum. And as you see it here, you see it there, you can't see it there, but it's there. It should line up in every single view. And if it does not, you have a dislocation. So this is very important for the distinguishing certain types of fracture dislocations. And so let's use our skills on this lateral with an ulna fracture. It's not quite a proximal ulna fracture, but the radial head should always line up with the capitellum. It does not. One could look at this x-ray and say, oh, there's an ulnar fracture, I'll splint and refer. But this is a child can have significant morbidity because this is a radial head dislocation. And this is called a Montasia injury. And it's generally fractured the ulna, often the proximal ulna with radial head dislocation. And here's an example of that. And again, on the same view, the radial head should always line up with the capitellum. And this is from Lauren Yamamoto's site I took a number of years ago. But you can see this. This is super cool. If you just practice this, looking at this all the time, you're not going to miss this ever in your practice because you'll look for it. This is a Galeazzi fracture, and what you can see, fracture of the distal third of the radius with dislocation of the ulna. This is pretty brutal too, although I find that this is not often missed like a Montasia injury. So I didn't cover a lot like Toulouse fractures and avulsion fractures and other things, but hopefully I gave you a good overview of the most common fractures in childhood. So thank you very much.